Welcome to IM Updates. This is Yan. In this episode, we'll cover key international guideline updates, new FDA approvals, and real clinical changes in practice from March 23rd to March 27th. First, on March 23rd, the Surviving Sepsis Campaign released International Guidelines for Management of Sepsis and Septic Shock 2026. There's a new emphasis on screening and antibiotic delivery in ambulances for suspected septic shock with prolonged transport times. A lower MAP targets of 60 to 65 millimeters of mercury are suggested for adults over 65 years old. Even stronger guidance against empiric, anaerobic, and antifungal coverage unless specific risk factors are present. For fluid management, crystalloids alone preferred over albumin, and active fluid removal is encouraged after resuscitation. Selective decontamination of the digestive tract in mechanical ventilated adults is endorsed as a preventive strategy in settings with low antimicrobial resistance. However, these changes are all graded as conditional with very low to moderate certainty. As for vasopressors, norepinephrine remains first line, but the strength relative to vasopressin or angiotensin II is now conditional. And for corticosteroids, certainty of evidence downgraded to low and recommendation remains conditional. Also on March 23rd, the Society of Immunotherapy of Cancer released clinical practice guidelines on immunotherapy for the treatment of renal cell carcinoma, version 3.0. For adjuvant therapy, pembrolizumab is established as the standard care, with clarification that other immune checkpoint inhibitors or ICI regimens are not beneficial. First-line therapy for metastatic clear cell renal cell carcinoma, 4 ICI-based regimens are FDA-approved and recommended, with emphasis on ipilimumab plus nivolumab for sarcomatoid histology and the lack of benefit for triplet therapy. For post-ICI progression, adding an ICI to a TKI after progression does not improve outcomes. Instead, TKI monotherapy is preferred. This guideline also expanded guidance on autoimmune disease, organ transplant, HIV, and older adults based on real-world data. Next, on March 23rd, European Alliance of Associations for Rheumatology released recommendations for the management of Behçet syndrome. For patients with mucocutaneous and joint involvement, refractory or intolerant to colchicine, apremilast, or TNF-alpha inhibitors are now recommended. For major organ involvement, there is a significant shift to upfront biologics. Monoclonal anti-TNF-alpha antibodies, preferably infliximab, are recommended for site-threatening posterior segment inflammation. For arterial aneurysms, infliximab is now recommended over cyclophosphamide for both induction and maintenance. For venous thrombosis, glucocorticoids and immunosuppressives, preferably monoclonal anti-TNF-alpha antibodies, should be considered. For active parenchymal involvement, high-dose glucocorticoids and immunosuppressives, preferably infliximab, should be initiated instead of waiting for failure of azathioprine. On March 24th, European Academy of Allergy and Clinical Immunology released Allergic Rhinitis and its Impact on Asthma, the Area Guidelines, Revision Part 2, on oral and ocular treatments. The guidelines favor intranasal corticosteroids over oral treatments as the primary choice for allergic rhinitis. Among oral treatments, second-generation oral antihistamines are preferred. Leukotriene receptor antagonist use is discouraged due to rare but serious neuropsychiatric side effects. They are not recommended as a first-line or add-on therapy in most cases. Topical ocular treatments are generally not preferred over oral antihistamines. They can only be used for a short duration, means 7 days or less, for rapid relief of eye symptoms in seasonal allergic rhinitis. and are now suggested over no treatment in perennial cases. That's all for guideline updates. On March 25th, the FDA approved relacorilant, a glucocorticoid receptor antagonist, in combination with nab-paclitaxel for the treatment of adults with platinum-resistant epithelial ovarian, fallopian tube, or primary peritoneal cancer who have received 1 to 3 prior systemic treatment regimens, at least one of which included bevacizumab. Median progression-free survival was 6.5 months in the relacorilant in combination with nab-paclitaxel arm and 5.5 months in the nab-paclitaxel arm. Median overall survival was 16 months in the relacorilant in combination with nab-paclitaxel arm and 11.9 months in the nab-paclitaxel arm. The prescribing information includes a contradiction for patients who require corticosteroids for life-saving indication, as well as warnings and precautions for neutropenia and severe infections, adrenal insufficiency, exacerbation of conditions treated with corticosteroids, and embryo-fetal toxicity. The most common adverse reactions were decreased hemoglobin, decreased neutrophils, fatigue, nausea, diarrhea, decreased platelets, rash, and decreased appetite. Finally, let's look at a study published on Health Affairs examining practice changes after adoption of artificial intelligence in assisted cardiac imaging, specifically CT-derived fractional flow reserve or FFRCT. After Medicare established coverage and reimbursement for its first service using AI, which is FFRCT, in 2018, it provided the opportunity to observe clinicians' adoption and examine changes in utilization, spending, clinician productivity, and patient outcomes associated with its use. This study found that use of the underlying coronary artery disease test required for FFRCT increased after its adoption, whereas invasive test use declined. Unmet per patient diagnostic spending for coronary artery disease increased. They found no evidence that adopting FFRCT facilitated earlier diagnosis of coronary artery disease, although clinicians saw a larger share of patients with coronary artery disease after adoption, and clinician productivity, that is, total visit count, increased. After clinicians adopted FFRCT, they observed a decrease in rates of cardiac-related adverse events among their patients. So, what do you think? Does FFRCT truly improve care, or does it shift utilization and cost without clear diagnostic benefit? That's all for this week's episode. Enjoy your weekend, and I'll see you next week.